So thank you for coming to this session. This is an awesome session. This is the one. You come to the right one. And this is called Consider Your Words, How Online Interactions Add Value. And so the setup is we have 3 speakers. They're going to talk about 15 plus minutes. And then we have like a 5-minute Q&A. So while you're there talking, so please write down some questions. And I'm going to run around with some microphones because this session is being recorded. So yeah, let's just have a dialogue. This session is only have 3 speakers. Most other session has 4. So we have some extra time. So if you want to like converse a little bit more, that would be really awesome. Okay, so the first speaker is Kunal Patel, and the title is Interprofessional Online Learning for Primary Healthcare Teams, Finding from a Scoping Review. Great, welcome.
Well, thank you. Wow, now that I've heard that out aloud, that's quite a long title. Probably should have changed it, but it's a bit late now, right? But look, it's Sunday morning, and usually at this time of the day, I certainly wouldn't be normally giving a lecture, not back home in London. It's usually football day, usually a bit of soccer. So we're going to hopefully make this a bit relaxed, and I'm not going to be too academic about things because there's a lot of detail online. I'll tweet later on about the report. You can get the link online and have a little bit more detail into it. But just to get the blood flowing a little bit, I just want to ask a quick question, literally just seeing who you guys are, because it's something to think about when we think about the word interprofessional. So I want to ask you guys, raise your hands if you're a physician. Okay, so we've got 3 there. Raise your hand if you're a physiotherapist. None. Okay, raise your hand if you're a nurse or nurse practitioner. 1. Okay, raise your hand if you're a speech and language therapist, or an occupational therapist, or a physiotherapist. Raise your hand if you're a technologist or an educational expert. Okay, so we actually have more people, non-traditional healthcare workers in the room. And that's kind of cool. I like that. I don't want to talk to medics all the time. So, that's always nice. But something to think about down the line in terms of how we approach healthcare and learning and collaboration. But to even get the juices a bit more flowing, I thought, you know what, I'm coming to California. I want to talk about nice things. And this guy's one of the nicest things I could think of, right? Yeah. And it's a bit sad what happened, of course. But that's him backstage on Young Frankenstein. And I kind of wish I could do what he was able to do in that film, if you remember the scene where he talks to loads of scientists and then shocks them by just saying, I'm going to talk about body reanimation. That would be pretty cool, but I can't. But his life was very interesting. And basically, his ex-wife was diagnosed with ovarian cancer, Gina Radler, many, many years ago. And he became a big advocate for cancer. But then he himself got diagnosed with non-Hodgkin's as well, not shortly after that. And then as we have subsequently found out that he passed away sadly due to the complications of Alzheimer's. So he actually, during that time, became a huge health advocate. But if you think about those unfortunate diagnoses that they had, there's a lot of interprofessional collaboration around those diagnoses. Cancer, dementia. You think about the teams that try to optimize patient care. That'd be, your physios, your psychologists, your physicians, your speech and language therapists, and so on. They've all got to work together interprofessionally to provide the best care they can for the patients. So if we were going to blow that up a little bit more, and we think about it from a global context, it is very clear that by 2035, we're going to have a massive health worker shortage. We're talking 12.9 million health workers by 2035. How are we going to fill that up? There are ways. We're not going to build new medical schools. It's just, there's no capacity for that. So we've got to think of innovative ways of training these professionals. But it's got to be in an interprofessional context because we are all trying to work together. We're all trying to optimize patient care. But interestingly, it's also got to be at the primary care level. This is the most important thing. If we're going to achieve universal health coverage and also get to those numbers and fill that gap of health workers, we need to train interprofessionally, innovatively, and also at the primary care level. So what we do at IHEED, we look at new ways of doing this and using an online learning environment to provide interprofessional learning. But to provide more information behind that, we decided to do a scoping review. Now, some of you might be very familiar with what a scoping review is. I mean, kind of wish we'd had these things today. They're kind of cool, but basically, scoping review is very different to a meta-analysis. It allows rapid searching of broader terms. So a good way of looking at it is like you can do a meta-analysis looking at all randomly controlled trials on ACE inhibitors and whether they affect the cough. But that's a very specific question. Whereas a scoping study, you can look at a few more questions, make it much more broader, make it much more rapid, and it gives you a general perspective of the field, but it can also then lead you towards a meta-analysis, or it can lead you to understanding whether there's a gap in the literature. And that's what we wanted to do. So we were looking at interprofessional learning, online learning, at the primary care level. And what we did, these numbers are all in the report, I don't want to fly through them, but you can see that after the search terms, there were over 1,000 papers. But interestingly, when you started whittling it down, we came down to 23. 23 papers, over the last decade, literally looking at primary care, innovative training that is interprofessional. Not great already, not a great start. I think we can already say there might be an emerging gap in the literature here, a little bit of a gap in the evidence base. But as we started doing it and looking into it further and using the structures of scoping reviews, so there's a very good paper by a chap called Arksey. Have a look at it up. He pretty much helped develop the frameworks for scoping reviews, and that's what we utilized. We were able to then look at the outcomes, educational outcomes that come out of these papers. And what you're able to see there quite clearly is that most of the work being done looks at the acquisition of knowledge and skills. Yet very little is being done on patient benefit, which is quite interesting, especially as we're now at an event which is very patient-centric focused, and that's how healthcare should be. But then you can also see some did look at the learner reactions, some did look at the perceptions, some did look at changes in behavior, but predominantly most of them looked at acquisition of knowledge and skills. And this framework, as well as the outcome framework, is devised by a guy called Kilpatrick. You can have a look at that up as well at some point. But what we found was that looking at these 23 papers, there were certain key outcomes that were coming out of these things. And basically a lot of them were you can see they were identifying that there was the potential of e-learning. Now we find that a bit frustrating because when you hear academics saying, oh, e-learning, oh, there's potential, you're like, oh, come on, a bit behind the times now. It's there, we're using it. So to see that it's still only in the evidence base that we're only realizing the potential now, we already know we're falling a bit behind. We do know it enhances collaboration and communication, and that's what some of the work showed. And you can see through those steps there, it can also improve cost effectiveness. But interestingly, the work was actually not improving isolation. They actually found that there was more learner isolation. And what we found interesting about that was that was actually down to the fact that there's this thing that we phrase in IT called the digital divide. A lot of healthcare workers would actually try to utilize something new, but because they're not used to the tech, because they've never been exposed to it before, they actually end up feeling more isolated. So that was quite interesting to see. But pulling that all together, what we were then able to do is actually what would be the implications from all this work that we've looked at, these 23 key papers. And again, I'm not going to read this out, but what I will highlight is a couple of very good ones, is that, overall, even considering that learner outcome problems that they had, you are able to overcome geographic limitations, and that's really important in primary care. And the reason why it's really important is because a good example would be what we've done with other research that we've seen is, let's say, in regions like Canada or even in West Africa and Sub-Saharan Africa, you find a lot of primary care teams are isolated, and they find it very difficult to communicate with each other. They're very difficult to train together in an interprofessional manner. So what you find is that online learning environments can certainly enhance that in a big way. And this is what we're now seeing through this scoping review. It can elicit quite a bit of financial gain. We find that the initial costs might be quite expensive, but over time, you find that the cost is actually much more beneficial. It's actually way more cost effective if you're allowed to provide these learning environments. Good simple examples, even the use of Skype, for example. A business account might cost a clinic a certain amount of money in the beginning, but then that's it. Long term, you've got a high number of users using it to communicate with themselves and provide what we call a virtual community of practice. It can also, the key thing is, it can be an effective method of education for busy primary care teams. And that's very important. The pressure on primary care right now is massive, and it's getting greater because we're not seeing, for example, here in North America, family medicine, primary care, the number of workers within that sector are very low compared to specialists. Yet they're the forefront of healthcare. So if there's a lot of time pressure on them already, we've got to somehow relieve that and provide them time for them to update their training, update their learning. But again, in an interprofessional manner where they're doing it with nurses, where they're doing it with their community assistants, and therefore getting closer towards optimized care. The key advantage is the flexibility of engagement, and that is working around the schedules ahead, but also hopefully providing protected time. But as I said, there are technical difficulties, and hopefully as we work on investigating it more and also providing better online learning environments, we can do that. And it is becoming more accessible. If I give you a good example of a primary care example in Kenya, where they actually used WhatsApp to create a little online learning environment. It was moderated. We had a high number of community health workers talking to each other through it, but motivating themselves and actually removing that feeling of isolation. And that was at a primary care level. Like they'd be delivering a baby one day, and the other community health workers would just have the clappy emojis just there, and it really got them going. And they ended up also asking about the cases. So it can be quite simple tools as well that provide this whole online learning environment. But the key thing is that last point, is that any future evaluations of interprofessional learning need to focus on the robust evidence out there. And as I said, 23 papers. So we have identified a huge gap. If we can get it right, we can focus on behavioral change, we can focus on cost effectiveness, and obviously and ultimately the benefits for the patients and the clients. Now I'm going to leave it there because I want to keep it nice short. And what I want to come back to is the fact that we highlighted in the room, there were only a few number of physicians here, a lot of technologists there. It'd be great to get a maybe discussion now or maybe towards the end or even afterwards. So how do you guys feel about how your current learning and collaborative practice is working? Were you at an undergraduate and at a postgraduate level trained in an interprofessional manner which you can then implement in practice? So I'll give you a good example. In EDs or A&Es, as we call them, or as I highlighted with dementia care and cancer care, there are teams that work very well together, and that's called interprofessional collaboration. But did they actually learn that when they were studying? Did they learn that at a postgraduate level, or did they learn that on the job? You find in certain regions around the world, particularly in Scandinavia, they do this very, very well. But we need to push that boat out there. We need to get it to every region in the world using technology, using online learning, and that will be the only way we can eventually get closer to universal health coverage and address the health worker deficit. So have a think about that in terms of how you've all worked interprofessionally, if at all. But look, if you have any questions, please ask and go ahead. Hi.
I'm going to come back to you with the microphone.
I had told Kunal that I put together a grant to do online interprofessional training for oncology teams to help them do a better job with reproductive health, that I could never get funded. But one of the things I found when I was doing the research for that grant is that there are now pieces of software like Citrix Go to Learning where you can do an amazing number of different things. For example, you can have asynchronous lectures that people can look at whenever, but you can actually break up into small teams and have a supervisor and have everybody online with each other, even though they might be sitting at home after hours in different places and working on a project together. So I think there's some really exciting things that you can do.
Oh, absolutely, and I'll give you a very cool example that I saw recently. So with Skype, what we were able to do with a group in the UK is that we were able to get numerous nursing students, physician and medical students, and also occupational therapists, and also nurse assistants, all within the one Skype room. And what we saw in this example was one of the Skype rooms was actually a TV studio with a sim man, and a simulated crash was happening at that time. And what they were advised to do was, between themselves, decide who the leader was going to be. They were going to manage that crash via the virtual environment. And it forced them to suddenly start thinking about working together. And if you get that at the right point, whether it be at the undergraduate or postgraduate level, and using software like you've highlighted, it can really work. Any other questions?
So my question, I guess, has to do with how we compare this with other approaches we're already doing. And I know in America there's a lot of experience with telemedicine training programs for family health teams, the ECHO models, which have done it in many different areas. And I know we replicated part of that in Ontario and Canada recently for mental health care in particular. And the focus was very much on the primary care teams rather than just the family doctors being involved in learning how to manage these patients. And just like you mentioned with the digital divide, there's potential concern that can people relate to each other and not just to be given knowledge, but also present the cases they're actually dealing with right now, which gets them engaged in a very personal way. And also learning how they can, through this 1 hour, learn to support each other, even though they're located in different cities, and build that capacity and support network, which is the main thing that actually where the feedback we're getting is that isolation was the strongest factor that they felt was actually broken through this medium, that they felt less isolated, less burnout issues, and less feeling of incapacity in handling these big challenges ahead of them. So are there any researchers looking at how we can add in the asynchronous components to models like the ECHO, which has already got a lot of policy support and a lot of centers supporting it?
Yeah, and there is an interesting, it's not me giving a plug, but next week at UN General Assembly, we will be publishing a report on how technological innovation can build and support primary care teams with the aim of getting towards universal health coverage. And isolation and motivation are key things all the experts have highlighted in this report. That will be online hopefully in the next week or so, so please have a look at that. But thank you.
Good morning. This is
Hi.
great. Thank you so much for bringing this to the conference. It's a really important area. Do you think that participation would be more robust if there were CEs attached?
As in accreditation, yeah, absolutely. And again, this is something that we've been advocating for years, is that commonly, whether it be CME or ideally what you want is quality assured postgraduate training. CME is all good. The problem is with CME is that we do it because we have to, not because necessarily we want to. But if you provide CE and accreditation or transferable credit quality points to what you do, it provides a reward, but it also provides a stepping stone for progression for all these health workers. If you just even want to do a module from a PG DIP online, you know that you could transfer that elsewhere if it is quality assured and has gone through an accrediting process at a university. So absolutely, yeah, it's essential if you want to really drive the training forward. So I think that's it. If anyone wants to talk to me about Blazing Saddles and that lovely camping and bean scene at the end, I'm more than happy to chat about that afterwards. But thanks again, and we'll move on. Thank you.
Thank you so much.